Today we will see, this afternoon actually, we will see 3 urologists that the basic requirement was publishing 2 papers. That happened with these the 3 fellows, of course, as you already see on this slide, and then we are already very, very proud of them. But of course, I mean, we need the committee, I mean, to judge of this, whether this is true, whether this is really their work, whether they really can think scientifically, and whether they really develop to the level of PhD level. And we believe that is happening, but this is why we have actually an independent committee. So our committees, I mean, actually professors from our partner universities, Professor Mátyás Benó, Csaba Bérci, István Király, Dániel Bányai, I'm reading so I don't make a mistake, Mirkos Damási, Zsolt Molnár is different because he's from Semmelweis, but still, and not a urologist, but he's a prominent scientist and also actually a very important player in translational medicine, I mean in our center. And then we have Kanem Fazekas, who is our biostatistician expert, and also Krisztina Csőke-Kabai, who is the SMS who takes care about all the details. But if anything goes wrong, that's my fault, not your fault, so don't worry. Okay, so with this word that I would just pass the chair to Professor Király.
Dr. Tamás Fazekas was born in 1992 in Miskolc. He is a faculty urologist at the Semmelweis University and at the same time a PhD candidate. He attended the Fényi Gyula Jesuit High School in Miskolc and earned his MD from the Semmelweis University in 2017. With summa cum laude, followed by a urology residency training between 2017 and 23. He broadened his academic experiments with a research fellowship at the Medical University of Vienna and completed the Harvard postgraduate clinical science training in 2024 and 25 and undertook a clinical observationship at the Yale University in 2025. His research focuses on evidence synthesis and clinical translational uro-oncology. Key topics are MRI-based prostate cancer screening and diagnostics, treatment outcomes, and BRCA-mutated metastatic castration-resistant prostate cancer outcomes. He also coordinates international multi-center registry efforts, notably the Oligomet project. During his PhD years, he published more than 60 publications, with a cumulative impact factor of over 190. 2 of these publications have been cited by clinical guidelines. And he regularly speaks at major national and international congresses and also gives educational lectures for the European School of Urology. He has earned several recognitions, including 2 scholarship prizes from the European Urology Scholarship Program and for the Harvard Medical School Scholarship Program. He also received 2 Best Published Papers awards, one from the Vienna Medical Chamber and one from the Hungarian Urology Association. He's an active member of the European Association of Urology, the Young Academic Urologist Prostate Cancer Working Group, and the Hungarian Urological Society. He's married, has 2 big boys and 1 little girl. He's an art enthusiast, including visual arts, music, literature. In his free time, he likes reading, gardening, playing the piano. As you can see, this is a very impressive CV within a short term. So especially if considering his young age and and a short time. So therefore, I wish you to follow this excellent path in the future. Thank you very much.
Dear chairs, dear committee, dear audience, dear colleagues, dear friends, it's a great honor to be here today and to give you a little insight what we did in the past 4 years. So let's jump right in. I strongly believe that precision medicine and individual targeted molecular therapy will bring a major breakthrough in uro-oncology. And therefore, my personal aim is to find biomarkers which can guide treatment and diagnostic optimization in prostate cancer care. And in line with this vision and mission, we launched 2 specific projects 4 years ago. In the first one, we are focusing on an earlier diagnostic disease state in prostate cancer, the magnetic resonance imaging in prostate cancer screening. And in the second one, we focus on a novel molecularly selected subgroup of patients, the so-called BRCA-positive metastatic castration-resistant patients with prostate cancer. Now let's move on with the first project. First of all, why should we talk about prostate cancer at all? Well, because this is the most common solid tumor in men. 1 out of 8 men will develop prostate cancer during their lifespan, and 1 out of 44 men will eventually die from prostate cancer. And it's really important that while the 5-year survival of localized disease is almost 100%, if it's diagnosed in a metastatic stage, it's reduced to only 33%. So it's not a question that early detection saves lives. But what do we have for early detection? Well, historically, we had the PSA-only pathway when we measured the level of PSA from the blood, and in case of elevated test results, the patients underwent systematic biopsy, where we took samples systematically from every region of the prostate. And although this pathway was associated with lower cancer-specific mortality and diagnosis in earlier stages, on the other hand, it led to an excessive number of biopsies, significant overdiagnosis, overtreatment, and an impaired quality of life. Therefore, this classic PSA-only pathway is not recommended by clinical practice guidelines. But what we have since this PSA-only pathway, but based on the diagnostic modernization and diagnostic advances, we have the PSA-MRI pathway. So in case of an elevated PSA level, the patients undergo an MRI examination, and in case of clinical suspicion, we are able to perform targeted biopsies, so taking cores straight from the cancer lesion. So in this systematic review and meta-analysis, our aim was to assess the diagnostic value of MRI in population-based prostate cancer screening strategies. And to reach this aim, we set up the following research framework. We searched for men in the general population, and we compared screening strategies incorporating MRI with targeted biopsies and compared them with PSA-only strategies with systematic biopsies. And we performed separate analyses based on the MRI threshold for biopsy indication, PIRATES 3 and PIRATES 4. And our primary outcome was the detection rate of clinically significant prostate cancer, and secondary outcomes included the detection rate of clinically insignificant prostate cancer, rate of MRI, biopsies, the adherence of biopsy, and positive predictive value for clinically significant prostate cancer detection. After our systematic search and study selection, we ended up with 5 RCTs and 7 prospective cohort studies comprising more than 80,000 men. And now let's see our results. We found that a PSA MRI screening pathway using a PSA cutoff of 3 for MRI indication and a PIRATES cutoff of 3 for biopsy selection led to lower odds of insignificant prostate cancer detection, lower odds of biopsies, and a higher positive predictive value for clinically significant disease detection. And at the same time, very importantly, while not compromising the detection of clinically significant prostate cancers, those who we would like to find. Now let's see what happens when we change the MRI threshold for biopsy selection to PIRATES 4. We can further lower the odds of insignificant prostate cancer detection, we can further lower the odds of biopsies, and we can further enhance the positive predictive value for clinically significant disease detection. Now let's see what's the cost of all these advantages of a PSA MRI pathway? Well, we have to perform an MRI in 8.5% of all the men screened. However, we know if the biopsy indication is underlined with an MRI examination and with an MRI suspicion, then the patients are more willing to undergo biopsy. We found higher adherence for biopsy indication among these patients. So, to sum up, we presented the first meta-analysis on the utilization of MRI in prostate cancer screening. We're able to include high-quality RCTs and prospective studies only, comprising a high number of screened patients. Therefore, our risk of bias was manageable, and our findings were relevant and robust. At the same time, our study is not without limitations. Actually, the number of studies which we were able to include was pretty low, which can limit our subgroup analysis. Classic diagnostic statistics were not feasible to be calculated, and we have no survival data which would be mature yet to assess for these studies. So we have shown that a PSA MRI pathway leads to fewer unnecessary biopsies. We can avoid insignificant prostate cancer detection while not compromising significant disease detection. And this means that MRI can mitigate the pitfalls of standard PSA-only screening strategies, and we need to reassess our approach to systematic prostate cancer screening. However, at the same time, we need our survival data to be mature from these studies, and the optimal setup of MRI is currently not known. Now let's jump a lot in the stages of prostate cancer to a very, very advanced, to the last disease stage for these patients, the so-called metastatic castration-resistant disease stage. In this systematic review and meta-analysis, we assessed BRCA-positive mutation patients in this really advanced stage. But what's the BRCA gene? Well, we know that 10% of advanced metastatic prostate cancer patients have are BRCA mutation positive, and probably this is one of the most well-known genes of all time, because this was the gene because of which Angelina Jolie underwent prophylactic bilateral mastectomy due to the increased risk of inherited breast cancer. And what this gene does physiologically, that through the homolog recombination repair complex, it's able to repair the double-strand DNA breaks. And in case of its mutation, the mutation burden in the cells is going to increase, leading to faster tumorigenesis. And in case of prostate cancer, we know that that these patients do far worse compared to the white type, as their survival is shorter by 50%. And due to the advances in the therapeutic landscape in the past 10 years, we can choose between several agents for the treatment of metastatic castration-resistant prostate cancer. And our aim in this study was to assess the treatment responses to first and later line available treatments in this novel molecularly selected subgroup of patients. And to reach this aim, we set up two clinical questions. In the first one, we assessed the proportion of the biochemical response rate. It's called a PSA 50 response rate. It means that those patients whose PSA is decreased at least 50% during their treatment, then those have this response. And in the second question, we assess time to event data such as progression-free and overall survival of these patients based on individual or estimated individual patient data, and we were able to compare first and later line available treatments. Now let's see our results for the second study. In the first treatment line, for abiraterone, 52% of the patients responded with a PSA 50 response, for enzalutamide 64%, and for docetaxel 55%. So nominally, enzalutamide-treated patients had the highest response rate. And interestingly, these data were endorsed by progression-free survival. Here you can see Kaplan-Meier curves from the individual publications. And interestingly, a random effect Cox regression model shown a 53% lower risk for progression for patients treated with enzalutamide compared with abiraterone. Now let's see later treatment lines. For patients treated with PARP inhibitor, 69% responded. of patients treated with platinum, 77% responded, and for cabazitaxel and PSMA ligand treatment, 28%, and 50% of them responded. Now, if we focus on the two on-label treatments, the PARP inhibitors and the platinum chemotherapeutic agents, we found no subgroup difference between these agents. And more importantly, this data was endorsed by the overall survival analysis, which showed no difference between the two agents, so PARP inhibitors and platinum chemotherapy again. Additionally, we performed median progression-free and overall survival pooling of prospective RCT data only of the PARP inhibitor studies, and we have shown that these agents are doing pretty much similar in terms of PFS and OS with a low level of heterogeneity. So as a summary, this was the first meta-analysis providing a comprehensive overview about PSA50, PFS, and OS in this molecularly selected subgroup of patients with metastatic castration-resistant prostate cancer. We were able to use individual or estimated individual patient data, and we could reach a high sample size for PARP inhibitor and platinum treatments. However, at the same time, this was not true to first-line available treatments, cabazitaxel and PSMA ligand treatments. There, the sample size was pretty low, unfortunately. We haven't found any studies comparing directly these agents. Our PFS was a composite outcome, and the BRCA mutation test method may have differed among the studies, introducing a potential risk of bias. And last but not least, there are only, at that time, there were only available prospective trials only for PARP inhibitor treatment. So as a conclusion, we have shown that BRCA-positive patients respond to all standard first-line and later-line on-label treatments with some notable potential differences. And more importantly, the PSA50 response and overall survival with platinum was comparable to that of those with PARP inhibitors. And we have shown that PARP inhibitors are similar to each other in terms of progression-free and overall survival. And why are these important for us? Because now we know that these patients can receive any first-line treatments, and platinum can be given to these patients with BRCA mutations. However, molecular marker-driven interventional RCTs would be needed to compare first-line treatments and PARP inhibitor with platinum chemotherapy. These are the two corresponding publications of these projects. And now let's make the final conclusions of the thesis. So in the first project, we assessed the early disease stage screening, the utilization of MRI in prostate cancer screening, and we have found that MRI mitigates the pitfalls of standard PSA-only strategies. It leads to fewer unnecessary biopsies. We can avoid insignificant prostate cancer detection while not compromising significant disease detection. And in our second project, we focused on an advanced disease stage, the mCRPC stage, on an overall subgroup of patients. We have shown that BRCA-positive patients respond to all standard first-line and later-line on-label treatments with some notable differences in the first line. And we have shown that platinum is comparable to PARP inhibitor in terms of PSA50 and overall survival. And PARP inhibitor compounds are similar to each other in terms of oncological efficacy. But just a few words about the impact of our work. These two publications are cited by the EU's prostate cancer guidelines in 2025, and it's really interesting that they even make a recommendation. So based on our study, the use of platinum chemotherapy is supported in patients with BRCA alterations after PARP inhibitor treatment. So after Tibor's very kind introduction, I don't really want to go into the details. I was really lucky to be in this program, and I had a really intense past 4 years with several ups and downs. And I think probably the most important thing is now to express my gratitude to all of those who paved the road. First of all, to my extraordinary and great mentor, Professor Tibor Szarvas and Professor Nyiradi. I would like to thank for all the support for the workers of the Department of Urology at Szemmelweis University. And secondly, the second most important mentors in my life were those in Vienna, Professor Szarok Szariat and Professor Paweł Rajwa from Poland. So they helped me really to get into this international scientific world. Of course, I would not stand here without Professor Péter Hegyi's work, and I would like to express my gratitude to my international collaborators from here, and last but not least, to my wonderful wife for guiding me all the way. She was next to me in every situation, and for my 3 beautiful kids. And I'm really thankful for my parents who cannot be here today. So thank you for your attention.
Congratulations. I have 2 questions. First, I would like to ask your opinion about the prostate biopsy. As you mentioned, several studies prove that the MRI ultrasound fusion biopsy provides much more higher diagnosis of the clinically significant prostate cancer. And I would like to ask you, what's your opinion about that target biopsy is enough, or target biopsy plus systemic biopsy would be preferred?
Thank you. This is a really important question. Well, actually, the current guidelines go for targeted biopsy only with perilesional sampling when this is feasible. And in case of some circumstances, for example, a high PSA density or a positive family history, even maybe in some cases without a suspect MRI lesion, the patient should undergo biopsy, or systematic biopsy. So there are many factors that we should consider when we are making a decision whether the patient should undergo a systematic biopsy as well. But in these studies which we assessed in the screening settings, methodologically there were some differences. So we tried to perform some subgroup analysis based on the type of biopsy performed, like targeted only versus targeted plus systematic. But our subgroup analysis did not really show any conclusions, which is the optimal method for that. So in my clinical practice and in my opinion, this is a really, really complex question where other factors such as PSA density, family history should be considered on an individual basis if you really rely on your radiologist who can read MRI, the right MRI with the right quality.
I have another question or remark. Your second topic was the treatment of metastatic castration-resistant prostate cancer with BRCA mutation. You presented the possible treatment options, and I would like to mention that the data from real world sometimes shows discrepancy from the primary studies. For example, when we measure the different ARPIs effects under metastatic hormone-sensitive prostate cancer, apalutamide and enzalutamide abiraterone was compared to each other based on the real-world data, which shown several discrepancies to the primary studies regarding the decrease of the PSA level, to time to decrease, and for overall survival. So, okay, that's all.
Thank you. This is a really relevant question as well. And so unfortunately, at the time when we performed this analysis, we started in 2021, there was not really any data out there, only about abiraterone, enzalutamide, and docetaxel, and we were not even able to extend our analysis to the metastatic hormone-sensitive stage. And to of my knowledge, the data, considering that, is really limited to date. We have just finished another paper for the prostate cancer guideline panel. Just, I think, Saturday night we finished it. Another paper on the genetic mutations impact on clinical outcomes. And even in that study, we were not really able to find studies with apalutamide which would have shown in BRCA-positive mCRPC patients. So apalutamide and darolutamide are really new agents. So I think real-world data has just been out there for a few years, and not even in molecularly selected subgroups. But these are really potential new drug therapies. So looking forward to for the future.
Thank you. The real world data are available in the past 2 years.
Yeah.
Thank you. Let me congratulations. It's an amazing work. My first question is related to the project number 1. Focus is on the PSA, but there are other tumor-specific biomarkers, for example, the pro-PSA and the Phi index. So what would you think about combining the pro-PSA or the Phi index with the multi-parametric or biparametric MRI? So it would be a really interesting question about the solutions or findings comparing the two markers with MRI. So what would you think about that?
Thank you. This is another very relevant point that you have raised. In this paper, we wanted to include novel biomarker-based strategies for prostate cancer screening as well. We know that currently the Stockholm 3 score was tried in a trial setting, and the 4K score in the ProScreen trial. So these are really similar in a way to each other, that they are utilizing the different levels of PSA isoforms, just like the prostate health index score. And unfortunately, there are not that many publications which would assess the integration of novel biomarkers in the treatment diagnostic sequence. But this is the third generation of clinical trials which are coming, like the ProScreen from Finland and the Stockholm 3 MRI trial from Sweden. And the key question here is, one question is, can we improve significant disease detection? Probably it seems that we cannot. We can just be non-inferior in a way to PSA only pathway or PSA MRI pathway. But the other question is cost efficacy. So we have seen that in around 8 or 10% of the cases, the patients would need an MRI. If you extend it to a population level, that's a lot of MRI examinations. And the problem is that this is a narrow resource, not only in Hungary, but also in the UK and in Scandinavian countries. So these novel biomarkers could help us to decrease the number of MRIs needed while keeping the significant disease detection the same. So probably, as of my knowledge, in Slovenia, their national screening program is going to integrate prostate health index. So this is going to be the first prospective trial or prospective setting when it's going to be tried in the screening. Our friends in Ljubljana, Tara Lozar, is working on that. And but unfortunately, in Hungary, we are not really getting to the point with organized screening. But let's see what the future brings. So.
Thank you. And the second question is related to the project number 2. So the BRCA mutations, even the germline or the somatic mutations, were identified during hormone-sensitive phase when the prostate biopsies were taken or the radical prostatectomy was performed. So all the clinical trials were in metastatic castration-resistant phase. So what would you think about this kind of, so taking samples in hormone-sensitive phase, but making the trials in the castration-resistant phase? So is it a problem, or it's good in that way?
Yeah, thank you very much. This is a very relevant question again. And well, I won't be able to give you a definitive answer. The data that we have is really mixed. I would start by, there was a paper in 2016 in JCO from California, which it was an umbrella trial. They used prospective gene sequencing and gene sequencing cascades for the same patients. And the title of the study is that limited clonal evolution and limited number of actionable, targetable mutations in oncology patients. And the main message was the paper. It included patients with prostate cancer as well. And the main message was that only in 5 or 10% of the cases, they observed the emergence of new mutations for which they would have a new drug or they would have any clinical implications. That's not that much. So probably it's not that of a big problem. But if we look at the funding trial from Colin Pritchard, who first described the genetic background of metastatic prostate cancer in New England Journal in 2012, he said that around 30% of the metastatic castration-resistant patients, we can find HRR alterations, and 10% of are BRCA positive. We don't see this in real-world practice, but that's a lot. So there is the real-world evidence, and what we see in these trials are not really the same every time. And generally in the clinical practice, as you have said, we perform sequencing from the tissues that we have. I think it's not standard of care in Hungary to take biopsy samples from during the course of the disease. I know some people who do it, but there is not really good evidence behind this. Another solution for this would be liquid biomarkers or liquid sequencing, like circulating tumor cells, circulating tumor DNA. And of course, all of this is not really affected the germline mutations because those are there since the patient is born. So probably liquid biopsies will be able to solve the problematic of taking tissue samples, but it has a lot of technical limitations to date.
Congratulations for this great job. I had a question for the first part, for the MRI. We all know that the interpretation of the multiparametric MRI is highly dependent from the experience of the radiologist. And do you think the inclusion of these large-scale studies is enough, or is it sufficient for you to assume that these MRI reporting the centers have enough experience?
Thank you. This is a really great question again. You're completely right. Both the quality, we have a scoring system for MRI quality, which I mean, if you have a score system for something, it must be important. So we have the precise score for MRI quality from 1 to 5, because it does not matter that how is the quality of the machine itself and the quality of the setting that it is set to at that day, on that day. So this is one thing that can be a limitation of the wide-scale adoption of MRI. The other thing is that the inter-reader agreement. So generally, these trials were run in high-volume centers and with a centralized image description. And in the Göteborg 2 and Stockholm 3, two of the biggest trials, they even published papers on the inter-reader agreement, and they reflected on the MRI quality utilized in their trials. So we know that in these trials, the inter-reader agreement was above 80 or 90%, so it was not an issue for them in the trial setting. What we see worldwide, and unfortunately in Hungary, that the quality of MRI and the readout of MRI is not ideal, let's say. So probably the most probably AI is sought to solve this question hopefully in the near future. And it's not going to replace radiologists, but it has the potential to serve as a tool in the hands of a good radiologist to help the diagnostics. So, yeah, but this is something which really limits its wide-scale interpretability.
First of all, I'm amazed by your scientific results, and I wish you great success in your future career.
Thank you.
I have two questions all related to the first study. First of all, we have clearly seen that there is a huge benefit in adding MRI to the screening process. All of the biopsies were MRI fusion biopsies, or were there among them cognitive biopsies or ultrasound-guided biopsies as well, just by adding the MRI in the screening process?
Yeah, it's a really good question as well. All of them were ultrasound-guided biopsies, but In some studies, MRI fusion was used, and there are other studies where cognitive biopsies were used. And we performed subgroup analyses based on this as well, but we did not really find any difference between the two ones.
So still the ultrasound guided biopsy is still okay without applying the MRI results, just by adding the MRI to the screening process itself?
Yeah, and actually this is something that aligns with the clinical scenario. So if urologists are generally performing, this is one of the first operations that you can do as a resident doctor. So the learning curve is not that steep, and usually a seasoned urologist has already done hundreds or thousands of biopsies. So if you tell them where to step the needle based on the MRI, that in this area or that area, cognitively they don't need the image fusion itself to perform the biopsy and find the tumor lesion. So compared to the old days when we had the ultrasound with questionable image quality or the DRE, this is much more.
I agree, there are ongoing studies regarding this, the comparison between cognitive and MRI fusion biopsies. And my second question before giving the microphone to Dr. Bertzi, that if you should provide a clinical recommendation for the office urologists, when to start the first PSA screening, and how should they schedule, and how should they perform the timing after that? I would love to hear about your opinion regarding this.
Well, I think it's not even for office urologists, because as I know, the GPs are going to get now the license for PSA screening, or not screening, but to offer the patient PSA test once per year. And actually, my personal opinion aligns with the clinical guidelines that in case of negative family history, the patient, the PSA test should be offered with the shared decision making, meaning that we should tell the patients the possible benefits and the possible harms that he can get from taking just one vial of blood, because we have seen that in the old days the PSA-only strategy led to significant overdiagnosis and overtreatment. So it's a shared decision. It should be consulted with the patient. In case of positive family history or African ancestry, which is not really common in Hungary, but in the United States it does, or in case of different ethnic groups like Ashkenazi Jewish, the starting age for a PSA screening should be much lower, 45 and 40. So.
And that's the clinician responsibility how to proceed with that, and I agree.
We did only RCTs, but the RCTs has a really strict inclusion criteria. So my question is, in your practice, how many % of the patients fulfill this inclusion criteria? So I mean, is there any selection bias? Because we regularly use recommendations and guidelines based on these RCTs, but maybe some patients do not fulfill this inclusion criteria. So what is your opinion regarding this?
Thank you. I missed the first part of your question, which was about, like in the second project, about that we included RCTs, or
yes.
Yeah. Well, in the second project, we were able to include RCTs only for PARP inhibitor treated patients, because they were not existing for platinum and for the standard first-line treatment. But the question is valid, so it's assessing the difference between what we see in RCTs might not fit the real-world evidence and the real-world efficacy, just as Dr. Bertzi has said with apalutamide and all these other agents. You should always keep in mind the difference of the data that you see on the paper, and you should always keep in mind the comorbidities and the selection in the RCTs. So you should always tailor what you give to the patient's needs, what they need, because that's the number one, what they want, what they need. You should tell them what are the expected oncological outcomes in this percent in 5 or 10 years. This is going to happen with you with this probability. You should take into consideration their personalities, their lifestyle, and their comorbidities, which is the most limiting fact in being enrolled in an RCT. So it's getting really complex, and it's even getting more complex with emerging agents and their treatment options. So,
thank you.
I have another question. For your first project, you mentioned that one of your outcomes was positive predictive value, and later, I was thankful for that. You also mentioned that it wasn't possible to analyze other diagnostics outcomes. How? It wasn't possible.
Yeah, why it was not possible to?
Yes.
Yeah, because the biopsy was not performed. So the reference test in a diagnostic setting is biopsy here, because that's the gold standard. If we want to know what's the truth, we may take biopsy from every patient. So biopsy was not taken in the screening trials from those who had PSA below the threshold, and for those who did not have lesions on the MRI examination. So therefore, for the calculation of sensitivity, specificity, and NPV, we would need to know the false negative rate as well. For PPV, this is a bit tricky. It's not a classic PPV. This is the positive predictive value of the whole treatment pathway. So it's, yeah, but this is how we came up with the name. So.
And also PPV is calculated with a given prevalence.
Yeah.
Which was the prevalence you calculated with?
Mm-hmm. Yeah, well, I think because PPV and MPV is affected by disease prevalence. So, well, actually, this is like emerging as a limitation of that. So we did not take into consideration the prevalence of the disease, and this would have been, I mean, a bit tricky again, because although the most populations were Scandinavian populations, there were some from the Netherlands and from other trial settings that could have been hard to set up one prevalence. But our PPV actually was the number of positives at the end of the MRI pathway, so the number of biopsies indicated versus the number of cancers found. So we did not take into consideration the prevalence.
Yes, so just the prevalence of the population that you included in the analysis. Yes, thank you.
Congrats on your nice presentation. It was very clear and easy to follow. My question is regarding to your first project, the population that you were working with. If I remember correctly, it was men from the general population. It seems very broad. What did the articles mention about this? Because I assume they were all adults, obviously, and were they men who showed up for a clinical screening test? Did they have a positive family history? Did they have symptoms or anything like that?
That's a great question again. Well, this man in the general population term was constructed because in urology and in prostate cancer diagnostics, we can talk about different populations. So we wanted to go for the screening setting, which is very different from those patients who go to the urologist with symptoms. So this is the clinical suspicion setting, and this is different, and these tests do differently in a screening-like population and differently in a clinical suspect population. So actually, we wanted to go as broad as we can for this, and we wanted to arrive at a screening-like population. So generally, we have talked about the indications now for PSA testing from the age of 50, and most of these trials enrolled patients from the age of 50. I did not show it on this slide, and actually, generally, no family history was assessed, or it was not an inclusion criteria. So these trials are tailored and designed to show the feasibility of these wide-scale population screening programs. So the mostly previous history of prostate cancer was, for example, key exclusion criteria of this, or if the patient was too old for screening, so above the age of 70 or 75, depending on the study.
Thank you very much.
Any other question? Okay, now the committee deliberates itself in a closed meeting to make our decision. Ladies and gentlemen, dear committee members and distinguished audience, after careful deliberation, the Defense Committee has reached its decision. We have thoroughly evaluated the dissertation, the presentation, and the candidates' responses to the questions raised. It's my pleasure to announce that the committee has unanimously decided to award the degree of Doctor of Philosophy to the candidate. Congratulations on this outstanding achievement. 100%.